Welcome to the Wellbeing Show. I'm your host, Noel Mcdermott. Got a great guest on tonight, Lorraine, who's a nurse and who specialises in psychosexual issues. I once said psychosocial because that's what I say all the time. As a therapist, I'm always about psychosocial. So psychosexual issues is her specialism. We'll get to that in just a second, what all that means. Just want to remind you, if you're listening to this on the 23rd of March, your equivalent of 9 p.m. UK time. It's live. It's a live podcast. We'd be great to hear from you. You can sort of drop us a line on any one of the social media platforms that are going out live on Facebook and YouTube, I think, are the two ones that we're going out on. But also, you can drop me a message on my phone on WhatsApp. It's +44 7506 319 745. James will put a link out to that as well. Give us a call or drop us a message. It'd be great to hear from you. I think that's enough from me. Over to you, Lorraine. Hello, Lorraine.
Hi, Noel. Thank you for inviting me along.
No, I mean, it's we were saying just before the show, I mean, I'm of an age where these conversations are part of my life. Sort of making sure that I'm medically okay, and issues around sexuality and all of that sort of stuff are, a part of who I am as a guy. So it's great to have you on, actually, as a specialist in the area, and hopefully we'll sort of encourage sort of conversation about it. I suppose before we jump into that and you get out your phallic things that you brought along to tell us all about the medics and the science of stuff, be nice to know a little bit about you and how you got into this, because you're incredibly passionate about what you do. You're a nurse originally by trade, is that right? You said to me in our chat on the phone the other day, you said, I was born wanting to be a nurse or something along those lines from a very early age, I think, wasn't it?
Sounds bonkers and corny, doesn't it? I've got a tiny little nurse's care from about the age of 3 that my parents got me, because apparently, I'd always wanted to be a nurse. And I remember playing with dolls and making little wards when we had wards where beds went down the side, the old nightingale wards. And I've picked the best job in the world. And I still think that 40 years later. So I'm a lucky woman in that respect.
Yeah.
But it's been even more enriched the last 28 when I've been dealing with men's health. I used to be a casualty sister, and then I used to teach trauma, and that was my big passion then. But actually, the transference of trauma from being a casualty sister to actually speaking to men and their partners about their sexual difficulties, it's traumatic for a lot of people.
Yeah.
And, I ended up doing a part-time job with a urologist, and my job interview was, you must have seen loads of penises being a casualty sister. The job's yours. And I was bright red and thought, crikey, I didn't. Funnily enough, the chap is Professor Roger Kirby, who's now the president of the Royal Society of Medicine, and Vanessa Kirby's dad, the actress. So Vanessa, I've known since she was tiny, and she's a wonderful actress. But isn't it interesting how things all move around? And Vanessa's done some brilliant work about female sexuality and with her artwork as an actress. And Roger, at the time, really empowered me and saw within me as a nurse about guiding me through moving into the field that I did. So I ended up being a research sister with Roger Tablet. And then the tablet I was handing out, and I was filling in the forms and bringing the diaries back. The patients were talking to me, and they were just being so open with me about their sex lives that for the first few months, I do remember thinking, flip, this is not what I'm used to discussing. But it soon became clear it's just part of health, and we should be addressing it. And that's...
absolutely. But it's interesting. I mean, I think coming from a nursing background. I mean, obviously, I have nurses in my services, but they're mental health nurses. They start off as biological nurses and they move into specialism. But in your specialism as a nurse, it was the body parts, and you just described that superbly. That you got into this field through the body parts, and it's always about the body parts in sort of mainstream medicine. But we forget there's a there's something else attached to that.
That's exactly what I say to people. That what led me then to do my psychosexual training was, it's not just a penis.
Yeah.
There's a man attached. There may or may not be a relationship, but there's definitely a brain. And then how the thought processes are around that body part not working hugely affects mental well-being.
Yeah.
And so I ducked out of being with you, didn't I? When you first reached out to me about coming on, I got a rabbit in the headlight, thought I've never done that sort of thing, and I politely declined the offer. And interestingly, when you asked me again, I actually thought, do you know what? This is like a man with a sexual problem. They avoid. They'll scarper away. They avoid. They put their head in the sand. That's ridiculous, Lorraine. Just say yes and you will do it. And go with the flow. And that's really the mirroring of my nervousness that men have.
Yeah, I think that's right. That sounds intuitively, that sounds absolutely spot on, actually, right? That sounds, but it's also, I think that, like the thing that we do in psychological medicine, we do it in physical medicine, we do it in all medicine, is somehow we try and create an emotional distance between what we do and the subject of what we're doing it to, with, or to, quite often, because it does evoke feelings in ourselves, I guess. And you had feelings sort of as a kid that you wanted to heal people and help people, and then you get involved in this field in terms of helping guys. It's an interesting thing that that as a specialist, which is what you are, you're a female helping males with sexual dysfunction, and I'm quite intrigued to that. Because I guess some people are just going to see it as a bit of titillation, but it's not about that, is it? I think there's an interesting dynamic going on, and I wonder how you see it, because you've thought this stuff through. You understand what I'm talking about. So
I'm really passionate about all people who have empathy and understanding if they want to help somebody. Yeah. But I have so many men over the years who say to me, "I'm glad I'm talking to a woman."
Right.
Occasionally, I can count on one hand the number of men, not even 5 actually, who have said, "I'd rather speak to a man." And I used to run a clinic at St George's Hospital in London for many years, actually. And I can remember...
St George's is an extraordinary hospital, for people who don't know. It is right up there in terms of the skills. And
it was wonderful. And remember, back in the 90s, Roger and I in this ED clinic that I set up, there wasn't anything like that anywhere else. So we were, people said, "Well, where did you learn?" And I went, "Well, I didn't, it wasn't happening, it was learning on the job, But at George's, there was a man who actually didn't want to see me being a woman. And I just said, "I totally understand that. You could see my colleague." And he eventually, several months later, because it took so long to get an appointment, came back to me because he'd been advised, "Look, you really need to speak to Lorraine." And he was apologetic. And I said, "Please don't be. At that time when we first met, you needed that support of speaking to a man." But most men are so... I've said it, I wish I had £1 for every one that's gone, "I'm so pleased I'm talking to a woman." Yeah. Or they might even say as well, "My GP's a woman, she's really good." It's so interesting how that is, but there is a thing, isn't it? Men want to talk to men.
So, I'm intuitively, I would say something like this, that there's a lot of competition around the functioning of the penis around men, and maybe that competition isn't there when it comes to the relationship to you. That would be my guess. Is that... Does that seem about right?
Yeah, it does. I've had men say that to me. I've had a chat once, I've actually resigned from my role. I can't sit around the boardroom with other men. Yeah. And so they'll compare themselves with others. And you're correct. I am a heterosexual woman and I haven't got a penis. So you're right. There's no penis envy.
Right.
And so it's been...
And so... Just thinking about that stuff, it seems to me, and again, it's something I've come across in my practice around the role of sexuality in terms of how men construct themselves, in terms of their identity. What's your experience within that? Because it seems to me the ability to be virile is more than just function. It goes into sense of self.
Hugely. Yeah, I'm from the northeast of England. You can probably tell by my accent, from Hartlepool. And actually, yesterday, I actually listened in to the parliamentary with Nick Fletcher talking about men's health and try and get the agenda of it. And he pointed out, you know, if you're a man in the north of England, you'll die earlier than the man in the south. And I feel, oh my God, I mean, it tugs at my heartstrings. You know, we've got people from the northeast who may not have the job options that we have maybe in the south, and their role in society, they might be the breadwinners. They may, you know, it's a massive thing. And how do they see themselves as a man? You know, I look back at certain people. I mean, Jimmy Nail is a singer. You know, we spoke a little bit about music. Jimmy Nail is a singer from the northeast. Sting is obviously from the northeast and talks about, you know, the shipbuilding, and he's done music about that. And, you know, and it's really powerful and it's very strong. And Sam Fender, actually, I tweeted about it at the weekend in the Times. He was talking about suicide risks with his friends have committed suicide. He knows people. And my casualty days and suicide is so embedded in me that people have got to listen seriously to people about their mental health and their state of mind. And I think men don't always have the language to be able to know how to express that. And it can be really difficult. And this piece Sam Fender wrote, you know, he said, I'm not a therapist, but men need to talk. What a powerful sentence. Actually,
I'm thinking about, because I'm intrigued by this notion of psychosexual, because we think of sexual as this physical thing. I think a lot of guys split off that a sense of it's a physical act as opposed to a connected emotional act and a relational act. But the psychosexual, why psychosexual? Why not just stay within the physical medical field and try and find pills and potions? What interests you about the psycho side?
I just found it wasn't ticking all the boxes in the help the men needed, just seeing me in my sexual side as a clinical nurse specialist in erectile dysfunction. That was my title. Or as Roger used to call me, Queen of the Erections. But, you know, and humour is how we manage sex.
Oh, yeah, absolutely. Seriously.
Well, actually, patient might, if he said, look, I want to go and see Lorraine, she's Queen of the Erections, the men would go, oh, right, yeah, I'm off. You know, if you say, actually, you need to see a psychosexual therapist, people will go, there's nothing wrong with my mind. But actually, I'm not saying there's anything wrong with it. I am just looking at you as a whole person and the psychological side, because if there is erectile dysfunction, any man at any time can have an episode of it and it stays with them. And it can brew up into this massive iceberg, you know. Underneath, they are panicking, they're stressed, but at the top, their outer self does not show it. And so the psychological side, sometimes I've just got to demystify that and say, do you know what? It's for me to help you in an area that you may not have thought about. So a big area of mine is prostate cancer, because Roger Kirby used to do the surgery and I would see the patients pre-surgery about what to expect. And a man doesn't know what he's going to experience. He doesn't know what's going to happen, really. It's all about physical. But as you pointed out, it's not about body parts. It's not just about the prostate. It has much more going on with that. It's about ejaculation. It's about being able to orgasm. And they are certainly orgasmic. It's very psychological. And our brain helps us with that. And so actually, it's no good, I feel, a urologist only answering the questions about function. We have got to look. And, you know, I think we've got to really restructure how we manage sexuality in healthcare.
Well, sexuality is a collection of body parts, emotions, thoughts, psychology, and relationships. And very much thinking about those interplay. And it's, you know, the penis is not the same as the bicep. The bicep will pretty much work, doesn't matter how I feel. I can sort of get the arm to go like that. Do you know what I mean? It doesn't matter if I'm in a bad mood, a good mood, I'm stressed or not stressed. Generally, it'll be fine. But that's not true of something like the penis, which will do its physical functions like peeing, without too much. I mean, I'm of age where even that's complicated at times, to be honest. So, but that's all right. I've got used to that as well.
But people, you men tolerate a lot. I think you lot tolerate a lot. Just get some help. Don't tolerate.
I'm one of those. I do go to my GP at the first sign of anything. So I've had the finger up the bum and all that sort of stuff to sort of check me out. So that's fine. My GP was hilarious about it. He said, "I promise you, Noel, I'm not going to enjoy this." Which is just really funny and put me at ease, and we've got a really good reputation. So I mean, I would encourage all clients to do this. I think it's it is not discussed enough. Prostate cancer is beginning to be discussed, but again, still not discussed enough. And the whole notion of erectile dysfunction becomes turned into a debate about whether there's a pill or potion for it. There happens to be. But again, that doesn't deal with that physical function, doesn't deal with the broader issues of male sexuality.
And people might be single and they aren't in a relationship, and then actually the functional side, they might say, well, okay, that's fine, but how do I then explain to somebody? And that's what I feel, listening to a person about what their needs are, where they're at in the dynamics of a relationship or not, or dating. It's about communication. And people get fearful, and I'll say, look, you know what, you need to be able to communicate with anybody you want to form a relationship with. And if that person isn't accepting to understand why you may be taking that, which might be due to ill health, do you really want to be in a relationship with that person?
Also, I'm going to go out on a limb here and say there's quite a lot of guys who are avoiding relationships because they have sexual dysfunction, and they just can't come to terms with that because they don't feel that they can do their bit in the relationship because of that. And this is going out to those guys as well. But A, there's help, but B, the solution is not to avoid, is not to isolate, is not to make it worse.
I mean, men have a voice. They've got skin that's warm. They've got touch. And there are so many aspects, whether it's same-sex relationship or it's heterosexual relationship. Sexuality involves many things, and actually the penis, as you pointed out about this function part, is part of a man. I totally get that and how they feel about it. But actually, their partner, to have someone who listens, is caring, and can touch, can kiss. The skin is a massive erogenous zone. This necklace, first time I've worn this to any professional thing I've done, is a vibrator.
Is it really?
It's a vibrator. And you can pull the chain off and it's got different speeds. And it pulses. And it's so interesting. I think it's really stylish. It's really nice, but it's interesting. So when I talk about vibrators, maybe in sex toys of all different types with patients, they might get very twitched by them and say, oh, well, I'll be useless then. And that's when I say, come on, let's think about this. If you're using a vibrator, it's not making you defunct at all, or if a partner is. It's just having fun, and sex play is explorational. Great. And we're going to recover and discover, I feel, where you're at now, because you come very negative often. But actually, when you just talk about things like we're doing, and you think, well, I've never thought about it like that, because to me, it's about the function of my penis. It's about language.
Let's go back a little bit, because I wanted to set the scene, as it were, that we're talking about something much broader than just simple physical functioning. But there is an issue about physical functioning, and it is of concern to quite a lot of men. And that tablet that you talk about is one of the most popular tablets around, that you were working on experimentally all those years back. And I forget what it's called now. It's a sort of
Viagra, and
that's it.
Generic name is sildenafil.
Yeah.
And I always think it's important men know what the generic name is. So that's the cheaper option. It's not licensed by Pfizer, and Pfizer's is licensed, so it's Viagra. Yeah. And that's what Viagra Connect is in chemists.
And the generic thing is what you'll get from your GP if you have a chat.
Yeah, that's right. But there's also a brilliant tablet called tadalafil Cialis, which actually, when you were chatting about your prostate and your urinary flow, I felt like saying, well, it's a good one. This one is licensed for men with low urinary tract symptoms. So that's what you're talking about.
Yeah.
And erectile dysfunction. So it doubles up, but it's the only tablet licensed to cover both.
Right.
Actually, some men can find if they've got these urinary tract symptoms, low urinary, and they go along to speak to their healthcare professional, that actually they may be able to get the tadalafil prescribed. It's a daily dose. And the daily dose can be used for erectile dysfunction. So performance anxiety
has gone.
Yeah, that's right. Because, if you take Viagra, it's, as you're looking, are you going to take the tablet? Am I going to have a nice, kiss and a cuddle? Will it go further? You start to build up anxiety. If you remove that bit of education, you might use a tablet for a while to get your mojo back. Sometimes.
So let's spend a little bit of time talking about the types of, if you like, medical issues that might occur that affect the physical sexual functioning, and then we'll go on to talk about some of the psychological things that might affect. That's all right.
Yeah.
So what sort of things sort of medically are you dealing with that might affect the sort of how the penis works and whether you've got desire and libido and things like that, and sort of what sort of checks might you be doing and guys need to be looking at?
So they should certainly be having a screening of the fat content of the blood, their lipid levels, because
why is that important, Lorraine?
Because if you've got a cross section through the penis, I mean, I've got a thing here.
I know you've got loads of helpful aids there.
I always find engineers are very good. How things work helps them. But I think all of us, if we understand, I've got half a man's head now, I always feel, because I've talked to men about sex.
Probably the best part, the best half. The other half isn't worth having, I promise you.
It would be in my eyes.
Just be aware that your microphone, when you turn your head away, we can't hear you, and then you're covering.
Sorry about that. Let me keep forward. So the picture with the needle going in and the circles, the red circle at the bottom and the two yellow. Yeah. The two yellow, they're your corpus cavernosa, and they go in your penis. There's a model there, the red bit.
Yeah.
The vessels in there need to be healthy, and they need to be elastic and filled with blood. Okay. It's like blowing up a football. When you're aroused and you want to get an erection, you're feeling turned on, your brain sends a signal to the nerve supply that's around your prostate gland, which is why men who have prostate treatment often have majority have a problem with their erectile function, because the treatment affects the nerves and they relax the vessels to fill with blood. So it's like blowing up a football. Once a football's to capacity, it's hard, and that's what happens to the penis. But if you've got a high fat content and the vessels aren't as clean as they want to be, especially the heart vessels. So interestingly, if a man has erectile dysfunction, it can be a precursor for 3 to 5 years before they have a cardiac event.
I've heard this before. And is the link to do with vascular health because of fat content?
Yeah, exactly. Right. So the PD5 tablets, which are Viagra, Cialis, Levitra, and Spedra, there's 4 tablets actually on the market. They all work on endothelial tissue, which lines those vessels.
Okay.
So, checking you've not got a high fat content, checking you've not got a high glucose content, that you're diabetic. Thankfully, years ago, 20 years ago, I would be picking up undiagnosed diabetic patients in my erectile dysfunction clinic. Yeah. Where now I think primary care and screening is brilliant, and that's picked up much earlier now. So
fat content, is that the same as saying cholesterol, high cholesterol?
Yes. Yeah, exactly. Right. So you want to keep the vessels as healthy as possible, but 50% of diabetic men can have erectile dysfunction.
Okay.
That's a high percentage, isn't it?
Yeah.
And 1 in 10 men generally. And people might think if they've got erectile dysfunction, oh, it's all in my head. And it used to be thought that, but 80% of erectile dysfunction is organic, ill health, and 20% psychological. But interestingly, there's an overlap. And that
So you're talking about the reason why the dysfunction happens, because sort of only 20% of the cases or why there's dysfunction is primarily the reason is psychological. I'm guessing that when dysfunction does happen, whatever the reason, then there are psychological consequences that flow from that.
Correct.
And then trying to unpick that is actually quite complicated, I think.
And that's
when people mix up the cause and the consequence.
That's right.
But we'll come to that bit later. So sticking with this sort of...
So diabetes, hypertension, high blood pressure.
Okay.
Some of the medications people get put on for blood pressure can cause erectile dysfunction. Some statins can actually
dysfunction. Statins are a response to cholesterol, right?
That's right. Yeah. So some men may be put on a statin, a diabetic medication, and an aspirin as a preventative thing, a risk assessment. So it's always helpful when there are any changes to communicate that with your GP, for example, if they're managing your...
And there might be some simple things to do, like, oh, you're just on the wrong statin here, try these ones instead, and you won't have the same problem.
Yeah, or looking at dose alteration. That could be one thing, the tablets, the nitrates, people with heart problems, I've heard people say, oh, I can't take Viagra or Cialis because I've got a heart problem. That's not necessarily true. Okay. If you've got a stable cardiac disease and it's managed, you can, but you wouldn't start somebody on one of these, like the PD5 inhibitors. They actually drop your blood pressure slightly.
Right.
But because people's side effect can be facial flushing and their face can go red, they think it's made their blood pressure go up. And there's a lot of anxiety around that. Or they can get indigestion and they think it's chest pain. Okay. So there's a lot of misinformation out there. So it's really important you ask these questions to the healthcare professionals.
And which is partly why we're encouraging this conversation, because if guys are reticent about saying what's actually happening, there's always, I presume you'll agree with this, it's better to catch things at the early acute stage rather than wait till it's become chronic and complicated.
Yes. Because also, even from a health point of view, and I would imagine you've seen this, it affects mental health. It just snowballs with that. So nipping things in the bud.
To be honest, I don't make a distinction anymore between physical and mental health. I used to. And when I first trained 30 years ago, because I am that old, I used to think that there was this thing called mental health and psychological health. But I just don't believe it anymore. The mind and body are the same thing. They're not distinct. Yeah.
I totally agree with you. And I think that's why there's got to be this massive shift how we manage. I think, so...
It's René Descartes' fault. It's his fault. The mind-body split. René Descartes was a French philosopher, famously called a drunken fart in a song about it. But this idea that the mind is somehow separated off from us is nonsense. It's not. It's a physical, biochemical response. It's also, interestingly, and I think this is also the conversation about sexuality, the mind is also a shared social experience. Like literally, the brain does not grow unless we're in relationship to another human being. I mean, you've seen those pictures of severely neglected infants, for example, who have smaller brain and they have big holes in the frontal lobes because of the impact of the neglect. So without genuine social interaction with other human beings, we don't grow. And that's true of our sexuality. And if we have issues that are embarrassing and shaming about our sexuality and we avoid, then that does make it 10 times worse, without a doubt. The way we overcome is by engaging in helpful, kind, professional relationships with people that we can discuss these issues and find solutions from. So diabetes, hypertension, high cholesterol, being unfit, I guess.
Yeah, obesity, correct. Yeah, absolutely. So obesity has a part to play with it. Low testosterone, people getting their testosterone checked, looking at, now I think you've got to look at, the symptoms there, but it's surprising the number of men, certainly diabetic men with low testosterones. And interestingly, if you've got a low testosterone, it then makes it sometimes that the PD5 inhibitors, those tablets we've spoken about, may not work. So to get somebody up to a normal level of testosterone, they may find tablets actually start working. And they may start that their mental health improves. They get their libido back. Their desire can plummet with low testosterone. So you're absolutely right. You know, obesity has a part to play. Smoking has a part to play.
Yes. Yeah. I mean, again, that's one that's not talked about a lot. What is the link? Is it because smoking constricts the blood flow?
It's the vascular side of it.
It is, right. Yeah.
I once saw a brilliant advert, and it was Swedish, and it was young men, and they had a bow tie, and the bow tie was droopy. And it was saying about don't smoke. Yeah. I just thought, that's fantastic. Can we have it in England, please?
Yeah, no, I agree. I mean, it's these things. So we start to put these things right. And also, I'm guessing, I don't know this. Well, I'm not guessing. It's more of an informed sort of statement. But alcohol and drug misuse would have problems as well.
Yeah, so recreational drug use, it alters your state of mind.
Yeah.
And there's a big thing of chemsex at the moment, and people using drugs for sex, but actually being mindful of your responses, how you're feeling, what you're experiencing, that's removed when you've got drugs involved.
Yeah.
So people don't necessarily...
Also, people die from chemsex quite. I mean, it's sort of like... and then sex life is definitely over. So...
inhibitions reduce. So there's riskier sex. Safe sex isn't always practiced. So there's I just want to point out, and I'm talking about men, but we're talking about smoking. But interestingly, the clitoral tissue is very similar to the glans penis. We've got lots of nerve endings in our clitoris.
Well, can I just check something out? Because it's, as far as I'm aware, in utero, a decision is made, but the clitoris and the penis are literally the same thing. It's just in utero, they do the chemical...
Yeah.
One forms into the penis, one forms into clitoris, but they're actually the same thing, which is what happens in transgender sex operations, isn't it? If it's a woman to a man, they reconstruct the penis from the clitoris, and then they do it the other way around if it's a man to a woman.
I don't do trans. I'm mindful of that. If I see somebody,
but they're literally the same thing, aren't they? They look different, but they're actually made up of the same stuff in utero. Is that right?
Yeah. And smoking, that was right. And diabetes. I remember being blown away at a medical meeting in the States where Erwin Goldstein, female sexual practitioner, blew my mind away when he said about smoking and clitoral tissue and the impact on diabetes. And yet again, I thought, no one talks about that. Yeah. But actually,
because of course the clitoris becomes engorged in the same way, doesn't it? And then it becomes much more sensitive, etc., etc. That's where the pleasure comes from.
So it's a massive sex organ. But when I go past shops in Oxford Street, if I whiz down from town, from clinic, and I might nip down, it's a lot of women outside shops having a cigarette. Not so much the men. And I'm always tempted when I see people to say, you don't know what damage you're doing to your sexual organs. But I think I might get punched. So I just walk on by as the song goes. But people don't realise.
So those are the major physical things that people can, and like lifestyle things that people can actually do something about and improve their sexual functioning. There's other issues, and this is maybe more my area, but it's also your area because you're psychosexual. But then there are things like anxiety and depression will definitely have impacts. Not so much psychosis in my experience, but the medication for psychosis.
Yeah, I was just about to say some of the
the antipsychotic medications are the biggest libido killer I've ever come across, and it's one of the things that, like, a lot of people who are on them are really upset about. They have no libido whatsoever when they're on sort of some of the older ones and the higher dosages, but certainly some of the SSRIs I know can have an impact on sexual functioning as well. Is that correct?
Yeah, they can. In fact, funnily enough, the SSRIs have been used for a long time for rapid ejaculation, premature ejaculation, because actually the side effect is delayed ejaculation.
Yeah.
But actually, there is a drug license for rapid premature ejaculation, and that's duloxetine, which isn't an SSRI.
Right.
But I prefer behavioural. management for rapid ejaculation.
Right.
Again, if you can educate someone about what's happening to their body when they're becoming aroused, what changes are happening.
Yeah.
A man then, through masturbation and self-pleasuring, can actually go through some techniques themselves to understand more what's happening to their body and why it's happening, rather than using medications to try and change that.
Yeah.
Because I think sex education generally has been pretty rubbish over the years. I can't remember it. It was biological from what I can remember.
If I remember it from school, what happened was we got so embarrassed we didn't really take much information in anyway. I mean, it was necessary. It was more about sexual safety than anything else.
That was good.
It was like avoiding pregnancy and avoiding STIs and all that sort of stuff. So, But I guess when you're that age, it's like, how much are you going to take in if somebody starts showing you pictures of penises and stuff like that?
Yeah, but I think that's where sex education needs to be more real. You know, we have conversations a bit like this, you know, where you can talk about things, show things. And I mean, I think Netflix sex education is fantastic. I was late coming to watching it. I watched it in lockdown because I had time to sit and watch TV, and everyone kept saying, you know, you must watch it, Lorraine. And actually, I think it's brilliant. There's really good messages they get out there. There's all sorts going on. It's raised awareness about the LGBTQ community, because I never assume that the man I'm seeing, I never know what sexuality that man sat in front of. So I assume anyone that I'm seeing would be LGBTQ plus.
Yes, quite, absolutely.
I think that's you saying about we can't differentiate between the mind and the body. I think we've got to see that whole person and find out for that.
Literally, my experience is, you know, the Kinsey scale.
Yes.
I don't know if you come across. For people who haven't come across it, Kinsey was a researcher in sexuality and sexual orientation a lot, and in sort of the early days. But he came up with this idea of this scale where there are some people at one end that are definitely straight, and there are some people at the other end that are definitely gay. But most people sort of fall somewhere along it. Not that everybody's mostly bi. That's not what he was arguing. But he said there's a lot of movement.
Exactly.
You know, and that's sort of like a more natural understanding of the way Mother Nature works anyway, because Mother Nature likes to give us lots of options rather than restrict them. But we tend to culturally and societally try to turn things into a binary understanding of things. But in reality, and I'm guessing as well that you will come across men who are playing roles that they're uncomfortable with. And that's what's affecting their sexuality as well and their sexual functioning.
Yeah, occasionally. Right. Not that often, in honesty.
Okay.
But I think sometimes there's definitely the fear and shame. You know, I've seen men who may say, I'm not telling the surgeon I'm gay, but they're telling me. And they will open up about their sexual wants and needs post-surgery, which fantastic. But it's interesting how they've kept it to tell me and not tell others. And that's, you know, again, I find that's a privilege, really, that we have this one-to-one interaction with somebody. It's confidential. And, you know, that's set very, you know, I think boundary setting is very good, you know. And it's a bit unusual, isn't it, really? And if you do a confidentiality agreement with the patient, which I do, that's something they're not really familiar with in general health setting.
It's extraordinary how few times you come across it. I do it religiously. And my confidentiality document is 4 pages long. There's so many possible scenarios and options, and we really spend some time discussing it with him. In terms of the guys that come in straight and gay, let's just use that very simplistic model. Having said that, probably it's much more complicated than that. Would you say the sexual issues that might come up, the sexual problems that come up, are pretty much the same for all guys? It's not relevant what the sexual orientation is?
I would say you're right. There will be the nuances of sex play that goes on with the dynamic of that relationship that will differ. But absolutely, you know, out with prostate cancer is I've got a great friend that I met through some filming I did with him, a gay man, Martin, and absolutely brilliant. He got me involved a little piece of this out with prostate cancer booklet. When he sent me it to look at with my little bit in, there's a bit about gay men talking about the impact of their sexuality. And I went, this is so relevant to straight men too.
Yeah.
If they could have just read this, they wouldn't feel as alone and as isolated as they often express themselves to me.
Yeah.
So you're absolutely right. It mirrors very well.
Yeah.
But there are those slight changes that they may present with as well.
I mean, I think it is sad that guys don't talk enough about this stuff with each other, because they'd actually find common purpose quite a lot.
Yeah, and everyone tends to, they've got the best size penis, they can satisfy every partner. No one likes to admit, you know, someone said to me recently, actually, it's not like I can say I've seen a sexologist and it was really helpful. I might have a nice haircut, or I've got a new jacket and I loved it and I'll share where I got it from. But it's a very intimate part of someone's life. So they don't share it, except they want to be seen in society that everything's working well, because we see it on the telly, we see it in the movies, you know, so they want to mirror what they're seeing around them and the shame.
And on that sort of notion of false imagery, and a lot of guys don't know this, strangely enough, a lot of guys are actually quite gullible about this, that pornography, for example, the men in pornographic films are not standard. Their tackle is not standard, guys. And when guys start, ordinary guys like me, start to compare ourselves to something like that, it is a very, very weird sort of set of comparisons to start with.
Yeah, the average penis size is 5 to 6 inches when you're erect. If you're soft, flaccid is the other word for that, you could be 1 to 2. But you'll be 5 to 6 erect. You might be 4 inches flaccid, but you'll still be around 5 to 6 erect. That's when you're hard. And porn,
the movie stars, it's not real, and it's not. And in fact, if you're watching Italian porn, it's not a real penis anyway. It's usually a rubber sort of dildo, to be honest.
Well, I've not watched Italian porn. I'll have to watch it.
And as you can say, I have these conversations quite a lot when it comes to it. Let's talk about some of those things about performance anxiety and the things that might affect in that sense, because you've begun to talk about it, and like the pills are not the magic bullet. They work, and it's great that we've got sort of medical backup, and I encourage guys to go and have a chat about it. But there is still there's a human being with their own vulnerabilities, and you know, say things like the Viagra type pill, the instructions are you take an hour before and you have to plan it, and they'll last for up to 4 hours and all that sort of stuff, and so it can get quite complicated, and other pills don't do those types of things. So
but it's the ability to get the erection within a 4 to half an hour to an hour. The ability to get the erection is 4 to 6. You don't keep the erection for 4 hours. And that's a massive thing that a lot of people say, oh, you know, I'm worried to take it because I don't want my erection to
That's right. I've been walking down the street at 12 o'clock at night with a boner going, what do I do with this?
They're the jokes you hear. And actually, a medical emergency is a priapism. And that's when an erection lasts for more than 4 hours. So that's something else I always give.
Not something you want in your life.
No, that's right. But to help to demystify some of the things where people say, oh, my erection's going to last too long, I don't want to try it, there's a lot of fear. That won't happen. It shouldn't happen at all. You only get the erection with the tablets, with touch, coming into what we're on about now, the psychology side of things.
Right. Let's talk about that, because I think, again, there's a myth about some of these chemsex things like poppers and stuff like that help with arousal, are sort of, they're more autoerotic responses, and we don't really need to go into what that is. There is a physical side of it because poppers give you an increased blood flow, that's all. And
the nitrates, where I got slightly diverse, you know, when we spoke about cardiac problems, and I said if you've got a stable cardiac problem, you're fine. But if you take nitrates, which relieves chest pain, the spray under the tongue, the little white tablet, you shouldn't use the tablets because they drop your blood pressure. Hence you know, you were saying about poppers, you know, they might be used quite a bit in the gay community, but they can drop blood pressures and you can collapse if you combine.
Well, I mean, I would always counsel people against using chemsex, full stop, because there are all sorts of complicated problems. And I know people are going to ignore me when I say that, but you're best to be honest, my experience is you're best to avoid using artificial chemicals as much as possible when actually what you want to do is engage in a sexual relationship with another human being. It's sort of, but if we're going to use them, and I think this is the point that you were beginning to make, if you're going to use this medication, it can be very helpful. It doesn't work on its own. You don't just take a pill and then you're suddenly turned on.
Exactly.
And I think people need to understand this, don't they? That
100%. That's why me going through the arousal side of things and how things work are important. So I like using like a tick box, and I'll say to a man, you know, tell me when sex was good. What was good about it?
Yeah.
And they may say I was on holiday. I was not made redundant. I was in a job. That tells me, you know, finances are a big stress, aren't they?
Absolutely, yeah.
Really, I got divorced, you know, and things haven't been the same since. But actually, when I was in this relationship, it was great. So I get them to think about when sex was good, and then bring that in with like a tick box and say, let's look at the circumstances that you know would work well for you to have a good sexual encounter, whether it's with yourself, with playing with yourself, or with a partner. And then they take responsibility and look at their lifestyle. It might be drug use. It might be working 60 hours a week and they're not relaxing.
That's right. Absolutely. But it's also, I think, what happens then when guys become literate about these issues, they can share them with their partner. And their partner goes, phew, thank God. I don't have to try and read your mind. I know I can do that. I'm going to do that. And then this is what I like. And then you can do that with your partner. And you've got a sort of a virtuous circle rather than a vicious cycle.
Yes, exactly. Yeah. Because actually, once you then are able to say, and if there is a partner, that partner often thinks there's something wrong with them.
That's right. You know,
they've put weight on, or they're not fancied anymore.
Yeah, absolutely.
He's having an affair. You know, all these conjure up in the relationship. But actually, if someone says, I'm absolutely knackered and I just, you know, thought of having sex now, you know, they always say, you know, watching Match of the Day and watching the footy on the telly rather than going up to the bedroom where your partner might be waiting, demanding sex. It's easier to stay down watching the football.
And I think a lot of guys don't honestly admit as well the pressure to perform when they don't feel like it, because they should somehow be able to just get on and do it and all that sort of stuff. Because that's
but the number of men who say as well, Noel, sorry, I don't want to forget telling you it really, because it's the number of men who say, actually, I miss the hugs.
Yes.
You know, they miss the hugs, they miss being tactile, the kiss, coming in from work, going out to work, those little touches, which are the intimacy. So the sexuality.
This is the point, isn't it? And again, coming back to the image of like the clitoris and the penis are sort of the same thing. They look different, but they are actually the same thing. They're just shaped differently.
Yeah.
They do exactly the same job, and they work in the same way.
Yes.
And actually, men and women and men, we are pretty similar in what gets us going sexually.
Yeah.
You know, we want a safe space, we want comfortable, we want our minds not to be cluttered by stress and anxiety, and our bodies hopefully to be working and well rested, and to feel comfortable and valued. All of those things, if we can get those and achieve them. Tell us about arousal, because I know you've got some things that you can show us about the arousal cycle, because I think a lot of guys don't understand the basics of how all of this stuff works, you know, their own bodies. I think women are often more educated about their bodies than men are.
Well, you know, I always think, you know, there's a lot of people call their vulvas vaginas, and you know, we think everyone knows, but not necessarily the case. But actually, you know, the brain is that big a sex organ to allow arousal. I like using the analogy of cooking pasta.
Okay.
right? You're going to cook some pasta and you put your pan of water on the hob and the water's cold, non-aroused.
Yeah.
I'm going to turn the water on. I want a nice rolling boil for about 6 minutes. So it's cooked nicely, al dente, done. Very happy. If I have that turned up too high, water spilling out everywhere, rapid ejaculation. I need to learn how to control, to move from arousal into the next phase. And I want that nice rolling boil to help me into my plateau phase, which men and women have. And that women tend to have a longer plateau phase. We can stay in it longer. Men can have the shortened one, as, for example, the rapid ejaculation. They've not learned how to control the feelings that they're getting linked in with their brain of that. This is when I wish I had a penis. I'd love to know, how heavy does it feel when it's erect? How do your balls feel? Because we know that the scrotal skin thickens with the engorgement of the blood when you're aroused, as breasts, nipples, lips, earlobes do. And I often think, oh, it must be so amazing to know what that feels like. So you move into your plateau phase, and then you can orgasm. And orgasm will be very much linked in with that feeling you're having, the emotional feeling, as well as the physical changes that are happening. So if you think back to the things we said a while back about ill health and having an impact, after we orgasm and ejaculate, you have resolution, and that's when the blood that came into the genitalia resolves back into the main blood flow. And a younger man can quickly respond again. An older man, it may take longer. But actually, ill health, and we mentioned some of the very obvious ones, I would say, diabetes, high blood, cancer, lots of surgery, traumatic things that can happen there, they will affect that arousal circuitry. But if we don't know those stages exist, we can't really comprehend what's happening to our sex life. We see it as all one big mess. And so I think it's really important people know the stages, to think, where in the stages are you having the problem? And then we can unpick to see how we can help that improve.
So there's two things I want to pick up there and sort of maybe highlight a bit. This notion of stages. I think stages is not just the arousal, but it's also life stages. And I think guys don't talk about this enough, that sexuality changes through your age as well. And what you want out of it will change as well, and that's okay. And I'm in my mid-50s now. It's very different how I experience my sexuality and my arousal to the way I used to experience it when I was, 18 or 19. When, to be honest, I'd shag anything that would let me get sort of. That's okay. I
love your honesty.
Well, it's the truth, I'd be shagging buses if I got away with it, and but it's like it's not like that for me anymore, and I don't want it to be honest. Sort of now it's more about the knowing the person who's in my life, feeling safe with them, and spending time with them, and our sex is part of a much broader thing. And I'm sort of not that interested in the way it was. I get it with younger guys who are still very much interested in running around, and younger women running around and doing all of these things. And I admire your energy. I just don't have it anymore. And I'm glad I don't have it. I'm comfortable with me. And I guess it's that sort of sense as well, encouraging people to understand where they are in their life and not to have inappropriate expectations.
Yes, but that's really relevant for young people as well, Noel.
Right.
And I think massively so. I see quite a lot of young people. COVID's had a massive impact on people. Massive. Yeah. Huge. And I think
COVID's had this really interesting impact, which is the spread of, I don't mean it in a bad way, but the increased use of cybersex. During COVID and lockdown, and people using Zoom to have masturbation with each other and things like that, which again, it always was happening, and it sort of exploded during those times. And it's a normal, healthy part of our lives, and that's okay. It comes with problems like revenge porn and things like that, and people need to be talking about this stuff, because if you don't talk about it, somebody can literally hold you hostage.
Yeah. And that's been happening recently, actually.
Yeah, and sort of we need to deal with it. And things like sending unwanted dick pics and all that sort of stuff. And it's now illegal in the UK, and it should be illegal. So it should be seen as, along with flashing and stuff like that, as sort of pseudo sadistic sexual behaviour that's dangerous. It's sort of, we have to be thoughtful about that. So there's all of that, but we don't have time to get into it. What I do want to come back to, though, is this notion of, you've used the word orgasm with men and sex. Now, culturally, orgasm belongs with women, but you're quite comfortable. You think it belongs with men. Tell me about that, why it belongs with men.
You know what's really interesting? I used to sit MDT, multidisciplinary team meetings, in the bowels of St. George's.
I've been at those. God, I'm not there anymore.
And I used to say, can I ask, it was mainly men in there, can I ask, the men are telling me they can orgasm after they've had their prostate removed and there's no ejaculation. And I was really laughed at, really. I was the fluffy one sat in the corner asking about, are they in a relationship or not? You know, and it's very clear it's a different pathway. And absolutely. So in fact, some of the men with prostate cancer who I see, I've had some men say their orgasmic sensation is better than before surgery, some who say they can't, and some who say it's about the same. And the men who say it's better, why is it? And they'll say, it feels more like I would think a woman's orgasm would be, which is an all over body experience rather than it being more pelvic focused. So 100% you can orgasm. And now, because orgasm and ejaculation almost happen simultaneously, people see it as the one thing. And it might just, so language is really important. It might be described as...
I would also tentatively, I would tentatively suggest a lot of guys have experienced ejaculations, but not necessarily orgasm. And sort of, in terms of moving into that and having that more all-body experience, is that something that guys can learn about as well and sort of work on and learn the techniques for? And what sort of pointers would you give?
Yeah, so touch is really important. Sensate focus, self-focus are exercises that sex therapists often guide patients to do in the comfort of their own home, and they will explore the response of their own bodies to touch and their mind and what they're feeling. So it's very much that mindfulness approach of the experience, not just the physical response.
I had a tantric teacher on some months ago, and again it was similar type of conversation. She wasn't medically trained, so she wasn't dealing with physical dysfunction, but she was working with a lot of men and lots of women, but a lot of men who had over the years become disconnected from a sense of self, of physical self. And couldn't feel connected sexually, and it has become much more of a physical act. I've got to get a hard on, I've got to put it in something, and I've got to ejaculate, and that's what sex was. And then they were relearning that it's much broader than that, and it can.
And that's where I think the psychosexual and the nursing side come beautifully together, because you can manage those things to holistic care, patient-centered.
For me as well, it's sort of, I don't believe it's possible that as a species we would have survived so long if nature hadn't allowed us to be very, very multifaceted in our approach to these things. And it's only recently we've discovered drugs that help us get erections, but these types of issues have been around for a long time, and there have been ways of dealing with it. And I think it's sort of, it's more about getting into a much more comfortable sense of self and sense of relationship to each other. And however we do that is better. And I think a lot of the issues that you and I are talking about are, this is very classic Freudian analysis, are that society has messed somebody up and we want to take away that messing up that's happened to them and just get them back to a state of being much more comfortable with themselves as human beings. With all the warts and all, I mean, I'm not getting to some ideal of perfection, but just being happy with me. And if I'm happy with me, I'm more happy in what I do.
And I think bringing that in with ill health, isn't it? You might have ill health, something that's
absolutely
particularly, and it's then saying, actually, let's try and make it comfortable for you living in the body that you have now. That may have been altered, and we can't change that because there have had to be some physical changes, but we can look at the bringing in that self-worth with yourself now as this.
I mean, I've done this work with people with learning disabilities, physical disabilities, etc. And just because you're disabled doesn't mean you can't have a full and interesting and exciting sex life. And there is no one way of doing these things.
Correct. Yeah.
We have got to the end of the show. I told you we would, and you wouldn't notice. Everybody. We literally have run out of time.
Carry on.
We could just keep going, right? And there's another hour of chatting about this. I told you, Lorraine, it'd be like this, because I know you were very anxious about, will we have enough to talk about? Will it be interesting enough? But I sort of knew. But we do have to finish there. You stay there, Lorraine. I mean, I think we've begun to touch upon some of the issues, and I think there's so much more that we could cover. So I would hope that you would think about coming back, Lorraine, at some point, and we can pick up some of these themes and sort of go into them in a bit more depth and complexity. But for now, we have to finish. So Lorraine, you stay there. I want to thank you for being a super guest, and thank everybody for joining us. We'll be back next week, and I have absolutely no idea who's going to be on, but there will be a guest next week, and I look forward to you all coming back to us. But for now, I'm going to say bye-bye, folks.